Hi everyone, welcome back to Neurospicy Nursing. Today we're going to be going over the musculoskeletal system. Um, it's going to be covering, um, the actual musculoskeletal assessment as well as some of the pharmacological things that we'll see for these individuals. The last lecture we talked about pain management through opiates and NSAIDs. Those are options for people having musculoskeletal pain, like if they have chronic pain, like chronic regional pain syndrome, or if they're having a flare-up from lupus or RA, or their OA is acting up. Those are all going to be treatments as well. But we're going to talk about it. So, one thing to know just generally about the musculoskeletal system, this is going back to anatomy, is that it helps provide structure and protection for our internal organs, as well as just overall. If we didn't have bones, we would be literally a sack of meat just on the floor. So just make sure that it may seem like it doesn't do a lot, but it does a lot and it carries a lot of weight as well. So one thing that is super duper common in our musculoskeletal system is going to be autoimmune conditions. Obviously, there's autoimmune conditions amongst all of the different bodily systems, right? But again, if it's autoimmune, it's most likely going to affect your whole body, right? Not just one piece. But um, in saying that, we have a few autoimmune diseases like RA and lupus that we're going to talk about. Multiple sclerosis is another one. Um, but if we do talk about it, it'll be more in the neuro section, just because it's more of a neurological disorder because it's due to the lack of the myelin sheath. So, RA. RA is going to be a symmetrical arthritis that normally starts in our distal joints and then goes up the body. It starts at the synovial fluid or the synovium, which is the joint lining. Then it's going to cause pain, swelling, stiffness. Some people get fevers. And eventually, if we aren't taking medication to slow the progression, it can lead to full loss of function. Um, so other things that rheumatoid arthritis is gonna also affect is going to be our eyes, our lungs, our heart, and our skin. And then just overall, they're gonna be very fatigued. Um, the biggest difference between RA and OA is again, one, it is going to be autoimmune. The other thing is that it's symmetrical and osteoarthritis is normally going to be unilateral. Obviously, again, you can get OA in both knees, right? But it's going to start on one side, and most of the time you get it on the other side, it's because of you're trying to compensate for the knee that's not working. All right, going into lupus, this is another obviously autoimmune condition. One of the things that are most commonly attacked in lupus is your kidneys. Um, Lupus also, um, over time, will cause organ failure, and it doesn't have any cure. There's just medications to slow it down. So, Um, gout. So gout is another type of arthritis, but it's specifically caused by the increase of uric acid crystals that have now deposited in the joint space, most commonly in your big toe. So a lot of times when we see this, it's due to, the kidneys not properly filtering and stuff like that, but also having a high purine diet, so eating a lot of red meat or consuming a lot of alcohol. Um, There are two medications that we're going to go over that are for this, but um yeah, that's all I have for you for right now. Okay, so osteoporosis, it is the decrease in the bone density in an individual. It can happen sometimes from certain medications like prednisone or, glucosteroids, stuff like that. Glucosteroids, glucocorticosteroids. I don't know why I can't say that. I'm so sorry. Um, but it's a decrease in your bone mass, and your osteoblasts are not building bone for how fast your osteoclasts are tearing down the bone. It's also seen in individuals who have low estrogen, but we'll talk more about that. So, when we're going over the assessment for the musculoskeletal system, we kind of talked about it in the head to toe, but you're looking at their posture, you're going to look at their gait. You're also going to look at whether or not they have any abnormal coloring, like redness or bruising. You're also going to look at their overall bulk. Are they really, really tiny, or do they have a lot of muscle, very muscular, um, or do they have very saggy skin? Also, you're going to look at whether or not their joints are deformed. Um, like for example, if they have like the Herbinger's nodes for like osteoarthritis. Um, and then we're also going to make sure that we're looking at their bones and stuff like that for warmth and crepitus. So crepitus is like that popping. So there's active and passive range of motion. Passive range of motion sometimes depending on whether or not they have a blood disorder, we might not want to do passive range of motion because it increases the risk for bleeding, but always make sure that whether or not it's passive or active, that you're doing it bilaterally to assess the symmetry. Um, this is going to be like you tell your patient, push away from me or pull me towards you. That's part of that range of motion. And then muscle strength, that's when you tell them, press down on my hand like you're pressing down on a gas pedal or bring your toes to your nose. That's what that is testing. All right, so kind of going into these medications, I talked about us going over NSAIDs. We went over them in the last video, so I'm only going to cover them like a little bit. Um, Glucocorticoids, that's what I was trying to say earlier. They're anti-inflammatory, but long use can actually cause osteoporosis and can lead to infections. You have methotrexate. It inhibits with folic acid, I've mentioned a few times. It also causes immunosuppression, and it has a lot of things to watch out for, like that it is painful, or not painful, but harmful to the liver. Because it's immunosuppressive, you have an increased risk of infection, and it causes bone marrow suppression, which can then lead to gingival hyperplasia, so the overgrowth of the gums. We also have etanercept, which can actually worsen heart failure and increase your risk for lymphoma. So if an individual has heart failure, it's most likely contraindicated in them. All right, so these are these gout meds that I told you about. The two really, really big ones are going to be colchicine and allopurinol. Colchicine is for an acute gout attack. Allopurinol is for like long-term management. So, other things that individuals who have musculoskeletal disorders have to make sure that they're paying attention to is their vitamin D supplements. Also, osteoporosis overall, um, you know, they should be taking calcium and vitamin D. They also, if they have low estrogen, they can take a serum like rifloxifene, which mimics estrogen on the bone. But just like estrogen, you have that increase of any of those DVTs/VTEs. Um, and then there's biphosphonates. Those are going to inhibit the osteoclast activity. So it's going to prevent that breakdown of bone. One thing about it though is that it can cause pill-induced esophagitis. So individuals have to make sure that they're sitting upright for at least 30 minutes after they take it and to take it with a full glass of water. And then there's a parathyroid hormone, which is given sub-Q, and that's for severe osteoporosis. All right, so here's me talking about that low purine diet for gout. Um, Again, red meats, organ meats really should be staying away from. Shellfish and anchovies. High fructose corn syrup is another thing to stay away from, as well as alcohol and some cheeses as well. They can instead drink, water, skim milk, coffee, and then cherries and things with vitamin C are actually really good for gout. All right, so one thing that's very important when we have a musculoskeletal injury is actually going to be going over the neurovascular check. Oh, I did forget to mention really quickly the etanercept and the methotrexate. Those are both medications that we can use for both RA and lupus. Those disease modifying agents or modifying drugs, and those help slow the progression of those diseases down. Um, and then for the neurovascular checks, we're going to check circulation. So this is really going to be like your 5 Ps, right? Which is pallor, poikilothymia, pulselessness, paresthesia, and pain. Um, so make sure that you're checking the distal pulses, make sure you're monitoring that capillary refill, and also you're noting the skin color that goes with kind of those 5 Ps. You're also going to ask them to like wiggle their fingers or toes. If they get a lot of pain with that, we're going to be concerned. And then sensation, can they actually feel you poking them or touching them? If they have no muscle tingling, that's a paresthesia. So this is a little bit of a case study. I'll give you guys a few seconds just to kind of look at it. All right, so for this, we see the symmetrical joint swelling, so we're going to assume that they have rheumatoid arthritis, especially because in the hands, remember, it starts in the hands and moves up towards the central portion of the body. Then, after that, we're going to inspect for joint deformities, like are their fingers turning away from their body, like away from their thumb? Do they have any warmth or redness? Again, RA, because it's a autoimmune condition, they'll have warmth and redness around their joints. And then you're gonna see about doing those active and passive range of motions. Do you know if they are having a flare up, it's gonna be a little bit harder for them to do those range of motions. But that's another thing to keep in mind. So DMARDs, I talked a little bit about this. The methotrexate, this is the one that you have to make sure that you're taking the folic acid for. They should be getting not live vaccines. And any signs and symptoms of infection, they should be telling us, like if they have oral thrush or anything like that, let us know. Or if they have, the gingival hyperplasia or anything like that. But we'll do it in combination with an anti-inflammatory for their disease management. Some people, if they have like chronic pain, they'll give them opiates. Do remember that opiates are only analgesics. They're not anti-inflammatory, they're not anti-fever, anything like that. They're only analgesics. Also, for the patient education portion, I talked about it. They have to take folic acid, report any signs and symptoms of bleeding or mouth sores. That's that oral thrush, or immunosuppression, and it causes immunosuppression. Okay, so make sure that you understand the full pathobiz of these conditions. I kind of just went over them briefly, but I wanted to kind of go over the things that maybe were most confusing. Also, remember the biggest difference between OA and RA is that when we do the blood test, they'll have a positive rheumatoid factor for rheumatoid arthritis, and they won't have that for osteoarthritis. Also, some other things that we're going to test when we do lupus, the ANA, um, that's another blood test that they'll get. They can also get something called a CRP, and this is just testing for these autoimmune conditions, right? That testing for that inflammation. Um, Also, make sure when you're looking at your patients that, yes, we have a checkoff list, right? And there are things that we're going to see in our patients that might not be on our checkoff list. Make sure you still write them down because that's part of your assessment, right? And then the other thing is make sure for pharmacology that you do understand what these medications, side effects, and the evaluation of outcomes are. Make sure that after you give a patient their, I don't know, naproxen, that you're going back in 30 minutes later and you're seeing whether or not their pain score has lowered. Um, if you know that they take methotrexate, take the extra time to make sure that you're looking for any signs of any beginning infections. Same thing with the anti-intercept. Look for those early signs of infections. Okay, well, that's all I have for you guys today. Um, and I'll see you in the next video, which is going to be our neuro assessment. Right? Bye-bye.